Hello, I'm Emma Martin, a clinical specialist working in advanced practice in paediatric ortho at Southampton, and my colleague.
Munzir Jabora, one of the pediatric orthopedic consultants at Southampton as well.
So our aims for today, we have been asked to present hopefully the most common MSK conditions that are referred in to us from primary care, go over some of the signs and symptoms of those conditions, look at some of the relevancy and some of the physical testing that we would do, any red flags that are relevant. Hopefully we'll be able to clear up when it would be appropriate to refer those patients in, and at the end, a few resources to go along with what we've discussed. So we're going to start by going over a few of the normal variants. This is a large chunk of the referrals that we get from primary care. So we're going to start with a bit of a poll to say, is there a time when GNU varus or valgus may be appropriate? And hopefully that poll will pop up, Holly. Hello.
Responses coming in. So everyone's kind of going yes. We've just had one person that said no, so currently the yeses are winning.
And do people want to have a bit of a stab in the chat at, let's start with varus, when varus might be considered normal? We can't see your names, only Holly can, so.
No one's putting anything in yet.
No, valgus?
Oh, so we've just had two people pop up saying infants and toddlers.
Okay.
Maybe 1 year.
Okay. Okay, I'll go on to the next slide and hopefully that will answer the question. So there's two really nice visual ways of seeing when varus and valgus is considered normal. So we've got the Selenius curve, which everybody hopefully knows about. I actually prefer the pictorial of the legs above, and I think that's much clearer to remember. So it's really normal for babies to be born with varus. Normally by about the age of 1.5, 2-ish, they should be nice and straight again. And then anything from 2, 2.5 onwards, they might become valgum, so knock-kneed. Hopefully by about the age of 6, they should have nice straight legs again. So thinking about varus and valgus, how do we measure it? So to measure for valgus, so you're going to get your patient to stand with their knees and their ankles gently touching if they can. If there's a gap between their knees, then we're most likely looking at GNU varus. So you're going to measure the distance between their condyles, their femoral condyles. So it's called the intercondylar distance. And we would want that really to be less than 6 if you're outside of the normal timeframes. For valgus, you'd be looking at a knock-kneed position, so there would be a gap between their malleoli, and you don't want that gap to be more than about 8 centimetres. So when do we want you to refer? If they are extremely out of the normal variant age, if there's extreme asymmetry, or if they've got significant pain that you think is caused by that varus or valgus. Next, super common one. Oh, do we want to see if there are any questions on varus and valgus? Sorry, we were going to talk after each condition, weren't we?
Yeah. If you don't, we will also do questions at the end. So no one's putting any hands up, and there's nothing in the chat. So we'll move on.
Move on.
Oh, sorry, Lucy's just popped up with a hand.
Sorry, if it's mild, are orthotics useful at all?
For which? For varus or valgus?
For either, I suppose.
Only really if there's pain associated. So if somebody was getting some medial knee pain because of the valgus position, I think ideally at that point they should be referred to us to have a bit of a closer look at them, because they shouldn't be having pain associated. But if they're pain-free, as long as they fit within the normal distances and the normal ages, then no.
Great, thank you.
There's no more questions.
Lovely. So we'll move on to in-towing. Incredibly common. It's a huge chunk of our referrals are for patients that in-tow. There are 3 main causes of in-towing. I probably should have put these in a different order on the slide to make it clear. I'd probably say metatarsus adductus is the least common cause. Moving on then to internal tibial torsion, and by far the biggest cause of in-towing in our toddler cohort is femoral anteversion, and then I'll go through each of them. So metatarsus adductus is exactly what it says. It's adduction of the metatarsal veins. They are born with this, and for most kids by the age of 3 or 4 it should have resolved, so they should just see over time just a gentle improvement. In terms of treatment, generally some gentle stretches, so literally taking the foot into a neutral position gently and holding it for as long as you can with a baby. Footwear advice once they're up and about walking, so decent supportive footwear. Lots of reassurance that the majority will resolve, because they can look quite severe when they're first born. If you look at the little picture on the right hand side, it can look quite significant. And there's a really nice leaflet produced by the Steps charity, which I've put the link at the end. It's a really nice leaflet that just goes through exactly what I've just said. It just backs up what you've said, and I think patients love to have a written printed resource. When do you need to refer? So if they're stiff, if you cannot push them back into a neutral position really easily, and if it persists past the age of around 4, then we would like to see them. Any questions about metatarsus adductus?
Nothing's popping up yet, unless any hands get raised. Nope.
Femoral anteversion, so what I said, it's definitely by far the biggest cause of in-towing in the littlies. So it's normal to have femoral anteversion when you're first born, so up to about 30 to 40 degrees in babies, and over time it should decrease. It's much more common in girls than boys. Ideally, the normal value of femoral anteversion, so you always stay in femoral anteversion if you have normal development, but it should go down to anything between 8 and 15 degrees is considered normal. And ideally, before the end of the 2nd decade, they should have reached this. In terms of treatment for femoral anteversion, it's reassurance that the majority of children are going to resolve. And also, even if they don't resolve past the age of 10, doesn't mean that the patient needs to come knocking on your door again because it hasn't changed. If it's not associated with any significant pain or affecting function, it's still not necessarily something that needs looking at unless it's significant. So yeah, reassurance, they rarely need physio. I think a large chunk of patients are referred for physio, and I think lots of community physio providers may still treat these patients. My opinion is it's a bit of a false economy because they're going to get better anyway. I don't think it's the physio that's made them better. If you feel they're really significantly weak in their glutes muscles, then some exercises may be of benefit, but for the majority of these patients, they don't need physio, nor do they need surgery, unless it's significant and it goes past the age of 10, and that's definitely something to be reviewed here. BISCOS, so the British Society of Children's Orthopaedic Surgeons, have produced a really lovely in-towing leaflet over the last few years, which is available on their website, but also I've put the link in the resources, and that goes through the 3 causes of in-towing. So when to refer? If it's significantly asymmetrical, if it's associated with pain, or if it's persistent, so if they have more than 15 degrees of femoral anteversion going into adolescence. So how do we measure? There are a couple of ways of measuring. With the real littlies, so the little babies, it's nice to get them in prone if you can, like wrestling a crocodile. Then if they've got significantly more internal rotation, so you're looking at more than 70 degrees and less external rotation, so less than 20 degrees, then you could say that they have femoral anteversion. Or I think for the older children, certainly, and maybe a more official test is Craig's test, which is what the picture on the screen is. So that's again with the patient in prone with their knee flexed to 90. You're palpating for the greater trochanter, and then you're just taking them in and out of internal and external rotation until you feel the most prominent part of the greater trochanter. And if nobody's done this test before, it is more obvious than it sounds when I'm describing it. And then you're looking at the angle between the line of the tibia and a line perpendicular to the bed. And that's where your 8 to 15 degrees can be measured quite easily with a goniometer if you have access to one, or by guesstimating. Any questions on femoral anteversion before we move on?
Nothing's popping up yet, and there's nothing in the chat.
So internal tibial torsion, again, is really typical between the ages of 1 to 3. It will often resolve a little bit earlier, so often by around the age of 4 years. And again, we've got the magic number of 15 with both of these, which is nice. So anything over 15 degrees is considered abnormal. Our treatment is exactly the same as femoral anteversion, so reassurance, telling them all of the normal figures of when you expect them to resolve. They rarely need surgery. They most certainly don't need physio. And again, the Biscos leaflet is really nice. It talks about internal tibial torsion. So really similar to the femoral anteversion, when should you refer? If they've got persistent pain associated, what I haven't put here is the asymmetry, if they're significantly asymmetrical, or if persistent, so more than 15 degrees into adolescence. And how do we measure internal tibial torsion? This is something called the foot-thigh angle, which is exactly what it says on the tin, an angle between the foot and the thigh. And that should be less than 15 degrees after the age of 4. Any questions on internal tibial torsion?
There was a question that popped up in the chat from
Yeah.
Peter. Are you more likely to see a greater degree of angle in children with hypermobile joints?
No.
Okay.
And we're going to talk a bit about hypermobility in a few slides. No, because femoral anteversion is bony. So what you might see is if they are more mobile everywhere, if they're just a little bit more lax or they're more mobile in their hips, they may be more likely to fall into a little more internal rotation, because that tends to be the kind of more relaxed and floppy position, but not true femoral anteversion because that is bony in origin.
Okay, and another one popped up. How do we tell the difference between femoral anteversion and tibial torsion?
Yeah, good question. So sometimes when a patient is stood in front of you looking, you can't tell, and that's why you need to do Craig's test and the foot-thigh angle so that you can differentiate. When you're seeing these really regularly, it becomes more clear, but when you're not seeing it regularly, use the tests, and that clarifies. Do you think there's any other?
Yeah, I think I would add, if you look at the patient from the front, and if the kneecaps are squinting in, if they're facing in.
So like the picture on the left?
Yeah, you see the kneecap is squinting in. This is usually a femur problem. And if the kneecaps are not squinting in and they are facing forwards and the kid is in towing, it's more likely a tibial problem. So it's a tibial torsion, in addition to the test that Emma pointed out.
Okay, and there's one more question. Is presumably, apologies for pronunciation, presumably a goniometer is required?
Goniometer.
Goniometer.
Ideally, for all angles, a goniometer should be used. We have a drawer full, and the drawer rarely gets opened. But yes, absolutely, you should be using a goniometer for measuring any angles or ranges. Yeah.
Okay, so we'll move on then. That's all the questions.
Just a quick point about femoral anteversion. I think everyone here should be reassured that you don't necessarily need to refer any intowing from a femoral anteversion before the age of 10. So I think everything up to the age of 10 will be just watch and wait. We don't tend to operate or any osteotomies before the age of 10 because they tend to recur back again. So can just carry on reassuring and that should be fine. Unless obviously red flags, asymmetry, pain, and if there's any other underlying condition driving it.
I think with femoral anteversion and tibial torsion, one of the biggest things for parents is the regular tripping and falling. And so lots of reassurance regarding that. So actually being an inter is quite fast. And it's too fast for them when they first start walking, and that's why they trip and fall, because they catch their toes get in the way. So even if the tibial torsion or the femoral anteversion is slow to resolve, which it can be because it can take up to the age of 10, that tripping and falling will improve unless they've got any coordination difficulties, which would be something separate as the cause. They will improve as the child just learns to control their body and their proprioception improves over with age. Any more questions, Holly, or should I move on?
No, we can move on.
So next one is a poll. So I'm not sure how you've set this poll up, if people are just giving lots of answers, but when do people feel that primary care should refer flat feet for an orthopaedic or podiatry/orthotics opinion?
You should be able to see the words pop up on the screen.
We can't know. I don't know how.
Okay. So we're getting, when should you refer? Pain, painful. Those are the ones that have been submitted so far.
I think if you touch
Deformity, discomfort.
Yeah.
Mainly around pain, discomfort, and
Yeah.
Yeah.
Anything else?
Balance problems. And if it's asymmetrical.
Asymmetrical, potentially, yeah. So we get an awful lot of referrals for flat feet or pes planus, and especially in young children, so babies and toddlers. So babies and toddlers should have flat feet. I'd actually be more worried if they had decent arches, because that would be cavus. So anything up to about the age of 4 that's when you would start to expect the medial arch to become more visible. A couple of reasons for that. The main one is that babies are born with a medial arch fat pad, which kind of blocks the view of the arch. And if you have a look at the next baby that you come across, you'll see it. It's really clear. They've got a really lovely big squishy bit. That starts to dissipate around about the age of 3 to 4-ish. And then also once they reach more like 4 years, the arch just starts to become a bit stronger and more visible. Something else that can drive pes planus and give them the appearance of pes planus or increased pronation is if they've got really tight gastrocs muscles. So how can we test to see if somebody is truly flat-footed or if they've got an element of pronation, making it look as if they're flat-footed, or a bit of both? So we need to look at the flexibility of the feet, and that's the really important thing with any pes planus, is whether they're flexible or not, because stiff, flat feet need investigation. So we do that with it's a test called the tiptoe test. Now, in terms of how good this test is, I have never been able to find any information apart from an archaic orthopedic book from years and years ago by a chap called Staheli, which some of you will probably recognise that name. So in terms of its reliability, I don't know, but in terms of officially, but it's a really good test. So what you're looking for when they go up onto their tiptoes is that their calcaneum should swing into a varus position. and you should be able to then see their medial arches. If they're too young to go on tiptoes, and even with the babies, you are able to see the start of their arch by using something called Jack's test, which is extension of the great toe. That does the same thing as the tiptoe test, so in your kind of non-ambulant patients. So in terms of treatment, if they're flexible and they're not getting any pain, they do not need any treatment. They don't need to be referred to orthopedics or orthotics or podiatry or physio. We would only use orthotics if they were experiencing pain in their feet, or, I mean, you know, if they were so rolled in that they were weight bearing on their medial malleoli, then absolutely they need something to prop them up a little bit. But if they're, you know, little tots and they've just started walking, you need to give them a little bit of time to improve that. What we do know, and I think it's a myth, and especially I find this with families from Eastern European countries, actually, is that they want insoles to improve the development of feet. There's no research that supports that theory. So the use of insoles does not change the way that arches develop. If somebody is collapsing their arches because of weakness, or they are getting pain because they're collapsing their arches, then insoles to prop them up and make them more comfortable, definitely. Otherwise, no. These patients rarely need physio. They might need calf stretches. They don't need a referral to a physio to teach a calf stretch. You are welcome to direct them to YouTube. Because unfortunately here we don't accept, physio don't accept GP referrals, so they have to come through orthopedics, and one of us has to see them, and just for gastroc stretches that seems a bit much. So when to refer if they're ridiculously tight in their gastrocs and they haven't improved with your initial stretches and advice, and if they've got true midfoot pain that is still there even if they're in lovely supportive shoes, then that does need to come to us for review. The likelihood is that they need some imaging so that we can rule out any tarsal coalitions which can give midfoot pain, accessory naviculae, collars, which is an AVN, or vertical talus. Say vertical talus, hopefully it would be a little bit more obvious than a pes planus. They tend to be more of a kind of rocker bottom representation. Any questions on flat feet pes planus?
I'm just checking the
us.
Yes, please.
Just checking the chat. Nothing's popping up, and there aren't any hands up.
Just to quickly sum up this slide. So I think if it's painless, flexible, flat feet, reassurance, no orthotics, and no referral. If it is painful, flexible, flat foot, you can provide orthotics as an insole. Stretches, again, very rarely, you don't need to refer these as well. It's just about insole stretches. If it's stiff and painful, these are the ones that need to be referred for STC, obviously, to assess and do x-rays and rule out the bottom differential diagnosis, which is coalition, accessory navicular, collars, vertical talus, or any syndromic spastic flat foot.
Yeah, I didn't mention these.
Yeah. Okay. Still no questions, so let's move on.
So next one, I didn't necessarily want to talk about this because it's a very big topic, and it's a topic that lots of people feel quite passionate about, me being one of them. And 1 minute for a slide probably doesn't go into it. So hypermobility is just a description of movement. So hyper meaning increased and mobility being movement. That's how I describe it to my patients. It's not a disease, and it's not a condition that automatically needs treatment. So the Royal College of Paediatrics and Child Health actually put out a really lovely position statement on Ehlers-Danlos hypermobility type, which when I went into it yesterday to check, the reference has been taken down, and says that it's under review. So I don't know if they've had some kickback from somewhere. The statement that I had taken from that before I got taken down was that the term hypermobility spectrum disorder is not a recognised entity in children or adolescents, that it's basically saying it's not a condition, it's just a description of movement. So saying that, I think it's definitely important for us to be aware of the mobility levels and the laxity of a patient, and the Baton scoring system does give information on that. I think you need to be very careful if you're using the Baton score, and anybody that hasn't looked at the criteria recently, I highly recommend that you go back and look at it, because there is really strict criteria as to how they score. So in terms of the positions that you're assessing them in, and I'll just whiz through it very quickly. So hyperextension of either the elbows or the knees has to be over 10 degrees, and that needs to be measured with a goniometer that we were talking about earlier. The thumb to forearm has to be with the elbow in extension, and the thumb should meet the forearm with barely any effort, not, you know, cranking, nearly snapping something. The extension of the little finger should be with the whole forearm supported on a flat surface, and then it should be going 90 degrees or over. So it's quite strict criteria, and my feelings on the Baton score is that it only takes those joints that we've just discussed into account. So actually we see an awful lot of incredibly hypermobile ankles that may score 0 on the Baton score, but that doesn't take away from the fact that they've got hypermobility somewhere else. So I think it's an interesting score, but I don't think we should rely on it as any kind of diagnosis. So bearing all of that in mind, we should treat them as we treat any other patient. Being hypermobile does not mean that you are going to get pain, and you might not be hypermobile and get musculoskeletal pain. When to refer, please don't automatically refer every patient that you feel is hypermobile. Saying that, if they are truly excessively hypermobile, or you feel very strongly that the pain that they're experiencing is to do with their hypermobility, then they may benefit from some physio or some orthopedic advice. Any questions?
Nope.
Wow.
They're saving them all up for the end.
No hate email at the end, okay? Okay, another really common condition that we get referred is toe walking. So idiopathic toe walking, etiology unknown, hence idiopathic. So this is, I'm sure all of you know, a diagnosis of exclusion. So we need to rule out any neurological or neuromuscular cause for the toe walking. Toe walking can be a normal variant. So up until the age of 3 or 4, it's sometimes just something that kids experiment with. If it goes on past the age of 3 to 4, you're kicking on into the diagnosis of idiopathic toe walking. Most of the research shows that there's a natural history of spontaneous resolution. So rarely do children go on into adulthood remaining toe walkers. You can often pick people that used to be toe walkers, because I can't show you because I'm on a screen, but they have a really distinct bouncy gait pattern, but they don't tend to toe walk anymore. We also know from the research that there are rarely any significant problems later on in life. It doesn't affect your bony development. In terms of treatment for these, there's no strong research for any one treatment. All of the treatments listed below have got studies for and against. In my opinion, and I think lots of the orthopods' opinion here, is that our kind of job, along with parents, is that we maintain their range of movement and range of movement in their calf muscles throughout growth. In terms of how we do that, so stretches and advice, and that's something that I hope could be provided in primary care, and advice about decent footwear. If they are becoming tight and the stretches and footwear isn't cutting it, then we can introduce splints, either night splints or walking AFOs, so ankle foot orthoses. If they become really tight, so they're not even getting 90 degrees with their gastrocs muscle, so that's with the knee in extension, then we have the option of serial casting, which is exactly what it says. It's a series of casts where we put them on a progressive stretch, really effective. And then the final thing there would be either a TA or a gastrocs release of some kind if they were too tight for any of the previously discussed options. So when do we want to see them in orthopedics? Definitely if you can't dorsiflex them past plantigrade, so neutral, so a 90-degree angle, when you've got their knee in extension, that means that the gastrocs or soleus or both are too tight, and we would definitely like to see them at that point, please. If they're getting pain either in their feet or in their calves due to the toe walking, we would like to see them. And definitely if they are having problems with functional activities because of the toe walking. Any questions on toe walking? Anything to add? Anything?
Really, I was pretty much well covered.
Yeah. There's nothing popping up in the chat. And no hands up.
So we're going to have a huge decrease in referrals for some of these conditions. No questions. So traction apophysitis, people may not have heard of this term, but it's a kind of a global term for lots of different conditions. I don't know if anybody wants to put in the chat what they understand as apophysitis and some of the named conditions, and I've given you some clues with some pictures. Or even talk to who you're next to.
Yeah. Nothing's popping in yet. Oh, insertional tendonitis.
So that's a slightly different condition, but they would have pain in similar areas, and we would more likely see that in skeletally mature patients.
We've got a couple more. We've got growing pains, severs, Osgood-Schlatter's.
Yeah. So I'd say those are the two most common, Osgood-Schlatter's and severs. So traction apophysitis is a traction, so a pull of where a muscle or a tendon sticks on to the bone over the top of a small growth plate. So I think apophysis is actually officially stands for something like growth from a mother bone or something. So it's your smaller growth plates that are on top of your bigger bones. And some of the places that we have those are the tibial tuberosity, which is where you get Osgood-Schlatter's, the calcaneum, which is where you get severs. There's another one which is quite common, but often people don't know about it, called Sinding-Larsen-Johansson, and that's the X-ray that's on the right of the screen, and that's the inferior pole of the patella. Then there are a gazillion places in the hip that you can get it, and the picture of the pelvis there with the red dots are the places you can get it. They really, the most common one that we would see is the AIIS, so the anterior inferior iliac spine, which is where your rec fem, so one of your really big quads muscles attaches, and that's quite a common place. In terms of all of these have typical ages that they would occur, and I'd say they're far more common than you may think they are. It might be worth, if you're querying this, to have a look at your secondary ossification centres and when they appear and when they fuse, because that gives you a really good idea of when you're more likely to have a traction apophysitis of these. So what is traction apophysitis? So it's caused by two different things. The first is growth. You can only get all of these conditions whilst you are growing, because once that growth plate is fused, that condition is no longer a differential. It's caused because the muscles have become tight and they're tractioning on the area that they attach. The second cause, the second factor, is it's classed as an overuse injury. Now, that doesn't always mean that that child is doing too much in the grand scheme of things. Often they're just doing a healthy amount of activity, but every time you contract the muscle that it's being caused by, it also tractions on that growth plate, because that's how the action of the muscle works. So, for example, in the knee, the quads pull on the tibial tuberosity, and that's what gives you knee extension. So every single time that they use that quads muscle, you're pulling on that growth plate that's already sore. If you add any kind of jumping or running or propulsive action of that muscle, then you're increasing that traction even more. So I always say to my patients, if it's caused by these two different things, these are the two different things that we need to address. So to address tightness, we need to do stretches. But thinking about the cause of this, it being traction, you need to be really careful with stretches because you could potentially make it worse if they're doing hardcore stretches. And in terms of the overuse, is activity modification. So not completely stopping activity, unless they're really, really irritable, then there might be a time that you would do that, mainly just to decrease the intensity or the regularity that they are doing activity. The most important thing after a rest, and this is with any condition, not just traction apophysitis, after an injury, after a rest from anything, is a graded return to activity. You will probably hear this more than we do, that a patient comes back to you and said, well, you told me to rest, it worked, but it came back as soon as I went back to activity. Okay, but you've gone from doing absolutely nothing to playing football 4 times a week. Of course, it's going to hurt again. You need to advise them to do something to bridge the gap between not doing very much and what they're hoping to get back to. So a graded return. When to refer to us, if your initial advice and management hasn't worked, if you're just not getting anywhere and the symptoms aren't changing, then absolutely come back to us. And there are some really nice leaflets there. I haven't looked at them for a while actually, but on the Healthier Together website regarding these conditions. Any questions?
Nothing popping up in the chat? Nope.
Cool. You'll be very pleased to hear you've got a change in voice.
Hi everyone. So I'll be talking about growth-related pain. So a very common condition, very common presentation, obviously at your point of care. And they come to us with the typical presentation is pain, which is mostly during the day around the thighs, calves, shin bone, behind the knee, but it's usually not joint pains. And are usually bilateral. Usually age group is between 4 and 6, sometimes up to 10. And they're all active, pain-free during the day, but then at night they have pain, and agony. They ask parents for some painkillers, and then this cycle goes back and forth every now and then. And when you see them, they examine normally, and the history, there's nothing really to pick on apart from this pain during the nighttime. So usually this takes maybe months, maybe years to settle down. And it's basically growing pains. It's growth related. And the treatment is just to carry on to be active, rest in between, simple analgesia, stretching, massaging, heat pads, I think work. Red flags, when to refer or consider investigating is pain during the day, pain and swelling around joints, pain after an injury, which is post-traumatic, any fever, other constitutional symptoms, and if they started to develop a certain limping pattern during the day. So these are the things I would consider red flags. Plus, I would also maybe check their vitamin D as well to make sure that is with normal. So sometimes vitamin D, we know low vitamin D drives bone pain. So if the vitamin D is way below normal, then replacement might be a good idea. Good. Yeah. Any questions about growing pains?
There's one there. So if the pain wakes them at night, is this significant?
Well, I would observe it and see if this is persistent, then yes, it is significant. So usually shouldn't wake them up at night. It's usually pain at the end of the day after doing a long day of activities and then evening and then take painkillers to sleep well. Very rarely it wakes them up at night.
But when it does wake them at night, as long as they're back to sleep with the simple analgesia, stretching, massage, heat pads, then within kind of 20 minutes or so, then it's fine that they're waking at night.
Okay. We did just have two questions that came in relating to the previous slide. So one of them was, with the graded return to activity, how long would you suggest? 2 to 3 months, or kind of the time frames really?
Yeah, and I think every patient is different. So I always try and explain it to my patient like a bit of a science experiment. So if you're adding something in, you only want to change one variable at a time. So either the intensity of the activity. So for example, if they can do half an hour of table tennis, that's not the same as half an hour of football. So treat all of your activities separately. So either increase the intensity of the activity or the time that you're doing the activity for. Let's just take football as an example. Let's say they're doing half an hour. They've been back doing half an hour for a week or so. They're totally fine. The next week when they're playing football, you could try 45 minutes. If that doesn't cause any problems, and with apophysitis, you need to wait until the next day, because sometimes it doesn't hurt until later. If it hasn't caused any problems, then the next time that activity comes up, you can add another 15 minutes, and so on and so on. So some kids could go from not doing very much to being back to full activity within 2 or 3 weeks. Some might get to a certain addition, so half an hour is fine, 45 minutes gives them pain. Then they need to come back to their pain-free level, do that for a bit longer, and then add in again. So thinking about variables, don't change more than one thing at a time, or you don't know what's aggravated it.
And then just one more question relating to that one. Is there a link to a table for the age ranges at which it can occur?
Yes, I could probably find one and get you to email it out, Holly. But I mean, very easily you can Google secondary ossification centres. If you just Google secondary ossification centres, it will come up with pictures, and they'll tell you when they appear and when they fuse. And it's between that age range that it appears and that apophysitis occurs.
Okay. Thanks.
Typically, Osgood-Schlatter's is 13, 14-year-olds, more common in boys. Sinding-Larsen and Severs are both typically 9 to 10-year-olds. Hips are much later, because your ossification centres appear and fuse much later. So that can often be 15, 16, 17, even 18 for the AIIS. There's also Iceland's, which is your 5th metatarsal, which tends to be slightly more in girls, and like 10, 11-ish. And in America, they see a lot of elbows, don't they? Little leaguer's elbow. We don't see that really here. But yeah, depending on the sport that they do, there's different ones that are more common.
Okay. Thanks. That's all the questions.
Right.
Cool.
So next, trigger thumbs. So I think congenital is a misnomer. So it's usually just a trigger thumb which develops after delivery. So it's a flexion deformity of the interphalangeal joint in children, and typically presents by the age of 1. And 25% of them might be bilateral. And the reason is the flexor pollicis longus tendon gets fibrosed because of abnormal collagen tissue deposition around the A1 pulley, which is basically at the base of the thumb along the skin crease. And then the natural progression is they usually trigger until they are fixed in flexion contraction. And then it's very unlikely that they resolve spontaneously after the age of 2 if they do have fixed flexion contraction. And then what you usually notice that there is some thickening around the base of the thumb, which we call as Notta node. And this is basically the thickened tissue around the base of the thumb. So I would definitely ask if there's any history of trauma, because if you have a traumatic injury and then it fractured or healed, or you have a traumatic subluxation, that's different. I would only x-ray them unless they have a history of trauma. Otherwise, no x-ray needed. It's just a clinical diagnosis. So treatment. So during the triggering phase, which is basically below the age of 2, stretching is very, very important, and they usually resolve spontaneously about 60% of the time. And then there is less than 10% who resolve after the age of 2. This is very unlikely. That's why it's a very small percentage. And then if they end up having a fixed flexion deformity after the age of 2, then it's going to be an operative procedure. And we tend to do it between the age of 2 and 4. Sometimes we push it up to the age of 4 just for surgical easiness. But usually they come in before going to nursery, I think, to get it done. It's basically releasing the A1 pulley. The moment you release the pulley, which is the tight band covering the flexor pollicis longus tendon, then you get instantaneous release and movement. There is a risk of recurrence after surgery, which is between 5 to 10%, which we want patients and families about. But most of the time they do really well and they're very happy within 2 to 4 weeks' time after operation. So my advice would be, as soon as you see them before the age of 2, encourage stretching a lot before they get fixed flexion contraction.
Okay. Just checking for questions. Nothing's coming in at the moment, and no hands up.
So it's another little poll.
Yeah, so I think there's a poll about this one. What would warrant an urgent or emergent referral for a limping child?
Fever?
Okay.
First one in. Fever, 48 hours, unwell, sudden onset, history of trauma, swollen fever. Recent trauma pain.
Okay.
So based on fever, sudden onset, and pain and swollen.
Great. Okay. So yes, I mean, if you think about urgent emergent referrals, probably is rule out infection or septic arthritis, and then obviously it's temperature and fever. I think at your clinical setting, that would be a less emergent referral regards to infection, but it might be a slipped upper femoral epiphysis. Those patients usually present with limp and knee pain most of the time, and they end up having being assessed for knee pain, X-ray done, X-ray is normal, and then they send home for just simple analgesia, watch and wait and observe, and then they be coming back and forth, and the background would be a slipped upper femoral epiphysis. So if it was acute, then they usually present as a traumatic hip pain, emergent, playing football, having an acute slip, and they come to emergency. But if they are slipping gradually, this is a chronic presentation. They usually have knee pain at presentation. They do X-ray of the knee, and the knee X-ray comes normal, and they send home. So I would recommend any patient with a limp coming with knee pain, screen the hips as well, and make sure that you're not missing SUFI. So a slip upper femoral epiphysis presentation, usually 10 to 15 years olds. They're usually overweight. That's a risk factor. Females, I'd say boys more than girls. If they're 10 and below with a SUFI, we usually screen for endocrine conditions such as growth hormones, thyroid function tests, and these are the ones who have usually more risk of having bilateral SUFI as they grow up. We usually have referrals sent for chronic SUFIs, which is basically the common presentation is knee pain. And then we've got the acute and chronic ones where has been lingering out for about 9 months and then playing football and suddenly got acute hip pain, comes to the GP, get an X-ray, and then it shows the SUFI, which is basically acute and chronic. And then the other ones is the acute ones will come straight to emergency. So that is the top differential for a limping child presenting at your setting. And then the next one would be Perthes disease. Again, it's not urgent, it's elective, semi-elective presentation. They're usually younger age group, 5 to 10, and they usually present with acute hip type pain, maybe acute onset 48 hours. It might be something like a transient synovitis, maybe like infection. They have an X-ray, everything normal, blood's normal, and then they come back again to your clinic setting, and then with hip pain, X-rays done, still normal. But I would just make sure and keep an eye on that this is not varices, especially in this age group. Varices could always also be bilateral, but they usually come in different patterns and different, I would say, presentation. So you might have one which is advanced, and the other hip would be just starting. So they could also be bilateral. Varices disease, also these all warrant straightforward referral to us urgently to keep an eye on them. And we love to intervene early in varices disease if they do show signs of risk. These signs is basically the hip migrating a little bit, or more flattening of the ossific nucleus, and more fuzziness or increased density, which means that there is avascular necrosis happening. And you've got limited range of movement, so basically abduction is decreased to about 30 degrees. They keep limping persistently, and then they take regular analgesia. It helps a bit, but then it comes back again. And these are patients who are quite really active, young, thin and lean, play lots of football, and suddenly they decline in their activity. DDH, obviously, big topic, presentation. If they miss the early 8 weeks check or the neonatal check, they end up being seen as a limping child at the age of 1 or 15 months. And obviously, you've got ligament discrepancy. Examining them on the couch, you can clearly see that there is limited abduction on the affected side. And then you can't really appreciate your ortolani or Barlow test at this age group to be just limited abduction in flexion and decrease on and shorter leg, which is the ligament discrepancy, and the limp. And this definitely warrants an urgent referral for us. It might be a bit different from centers to centers. We love to operate on them from 1 year and above. But if you work in a different region, it might be a different approach. But if you see DDH, just straight away, it's going to be a straightforward referral to us to X-ray, follow-up, consider a surgical intervention, especially on the walking age group. They have already passed the non-operative measures. Infection, as everyone pointed out, in the cold fever is the main presenting sign. It's usually insidious acute onset, and then trauma is usually preceded by trauma, and you keep limping. But trauma can also precede infection. Trauma can also cause a slip upper femoral crisis, and a hip X-ray will help in triaging and decision making. So we got lots of referrals coming for advice and guidance, and referrals coming for triage. We would really appreciate it if you think anything regarding to a limping child, DDS, SUFI, versus just get the hip X-ray straight away. It will make things a lot more easier for us to triage and to say that overbook urgent or routine clinic appointments.
Any questions about the limping child?
Nothing coming in yet. Nope.
So there's a page here, and I think the presentation will be available, of some links of some of the bits that we've talked about. And I think, in summary, kind of understanding what your normal variants are and the typical ages will really help you guys in feeling confident to reassure the parents and when to refer to us. Please assess the patients, so objectively assess the patients and include that in the referral, because that really helps us with triaging as to who would be the most appropriate clinician to see them and the urgency of the referral. lots of things can be managed in the community really, really well. So referring to orthopaedics only if the initial management and advice has been ineffective, or we do understand that some are referred to us, and we can understand in the way that you've worded your letters that you have tried and that they need to be seen by a specialist to say exactly the same thing as you have said. And we absolutely don't mind doing it if you really have not managed to reassure them. We understand those patients. And then, yeah, ED for any emergency conditions.